Hi, everybody. How's everybody out there doing? For those that don't remember me, I am Stuart Schlossman from MS Views and News. We are doing a very, very special program tonight. We have a live audience out here. We are in Columbus, Ohio. We have our speakers on the stage. We have Sarah from Cincinnati. We have Dr. Boster. And this is an MS Views and News program called MS Conversations Now. So we want to first thank our sponsors of tonight's program. We have Novartis and we have Bristol Myers Squibb. And you know, we couldn't do these programs without them, so I'm hoping that our live audience appreciates this, as well as our virtual audience, and yay, let's hear about it. Let's hear how appreciative we are. Thank you. So, tonight's program is extremely different. Again, we have a live audience, we have a virtual audience. We call this a hybrid event. We did this once a few months ago in Roanoke, Virginia, but our team couldn't be there because we're from Florida. And the people in Roanoke, when the numbers were going up, said, whoa, we can't allow you guys up here. So we had to have our local people that were there doing the support group get into that location and be able to control the program from the inside, while I and our video team and our video producers were in Florida controlling the event from Florida. Very strange. So again, this is the first time since March that I have been at an in-person program. And coincidentally, we're at the very same location. We were here in Columbus, Ohio, at the same hotel. Of course, the room was more filled. For those that are online watching, we have tables 20 feet apart. We only have 4 people per table. We're keeping very socially distanced. Many times you see me online that I start the program with a mask on and I take it off because really there's nobody out there. But tonight, this mask will stay on, as is everybody else's, except while they're eating. All right. For the local people, we have index cards on the tables, or I will go around and during Q&A, you could call out your question to me. I'll either take it from you on the index card, or I will, you'll call it out to me and I'll just call it out so everybody else can hear this. For our virtual audience, please know that you can type in your questions. Please keep it relative to what the topics are being discussed. Our program tonight has many different topics. For those that are online, you do have the information. For those that are local, those that are here now, it keeps coming up on the screen behind us. And you'll hear Sarah announce the topics as well. All right, and Sarah's going to be having just a conversation with Dr. Boster about these different things. All right, and intermittently, we're going to do the question and answer after each set of topics is discussed. Again, this is a different type of program. We're used to just doing this virtually, and now we're doing this as a live program. So, again, let's just get started very soon, all right? So we have our people that are in our control booth. They'll be taking the questions that are online. We'll have the people that are in the audience asking questions as you see fit to ask. And right now, why don't we just get started, because we're going to have a great program tonight, all right? So I'm leaving up to Sarah and Dr. Boster. Let's make it happen. Thank you.
Thank you, Stuart. Thank you so much for putting this program on for us. And Boster, thank you for joining us. If there's anything that multiple sclerosis patients understand, it's the threat of disease can't stop us from enjoying living our lives. We just have to modify it and change it. And I think that this is a perfect example of that, just a different situation. So thank you so much for being here with us tonight. Tonight we'll be discussing a variety of topics, just as Stuart had said, including managing MS symptoms, stem cell therapy, and yes, COVID-19. First, a discussion about MS progression. So Dr. Boster, can you tell us about progression? What is it exactly?
Absolutely. Progression has a very negative connotation, and I can't tell you how many times a patient has said, please don't tell me I have secondary progressive MS, as if that would be like stage 4 cancer. The reality is that MS is a progressive disease since day 0, and progression can occur in 2 ways. You can have an attack, like let's use an example where you lose vision in an eye, and then it comes back halfway. So your eye's not the way it used to be, and now you have a chronic impairment, and so you've accrued some neurological disability. That's one way of achieving some progression of disease. And we now call that RAW, relapse-associated worsening. There's another way that you can progress, and that's where you lose neurological function completely independent from attack. We call that PIRA, progression independent from relapse activity. And the reality is, if you watch carefully, that happens early on in the disease the same way it happens later in the disease. The good news is there are things that we can do to slow progression. So the disease-modifying therapies, particularly the newer ones, are remarkable at slowing both raw and pira. Adhering to a healthy diet, supplementing vitamin D, exercising as part of your lifestyle, not smoking things. All of these contribute to minimizing or slowing progression of disability.
Okay, and is age a factor?
Age is a factor. Duration of disease is a factor. Both of those can play a role. The reality is we don't get to pick how old we are. We don't get to pick how long we've been diagnosed. But it doesn't mean that we can't rail against that and slow that down.
Okay, and so can progression be reversed?
Sometimes disability can be reversed. There's a really exciting term, probably the best, most beautiful 3 letters that I could ever utter is CDI, Confirmed Disability Improvement. And with some of the MS therapies, particularly some of the newer MS therapies, we can see that. So we can see someone, for example, lose a cane. We can see someone regain a function they didn't have. I'm not selling snake oil, like for a limited time only. If you sign up now for $9.99, that'll happen.
Right.
But what I mean is we are able to demand stability and ask for improvement in the modern era, which is awesome.
Okay. And you had talked about a healthy lifestyle. So what are some healthy lifestyles? You had mentioned diet and exercise. How does diet and exercise work for us now in the area that we're in?
So if we think about exercise, for example, there's very strong evidence that people with MS who exercise as part of their lifestyle end up less disabled when they're older compared to those that don't. And there's evidence that people who exercise as part of their lifestyle improve their cognition, their mood, and their energy levels. 3 nasty invisible symptoms that many people with MS are plagued with. Mm-hmm. But also, being physically fit is protection against your next attack. So if I give you a weird example, let's pretend that I cloned you, right? So now there's 2 of you. So we're gonna have to talk to your husband about that. So there's 2 of you, and we're gonna give one of you an elliptical, and we're gonna give one of you Days of Our Lives television. Mm-hmm. So the first version of you becomes rather fit. She has a strong core, strong lungs, her balance is better, cardiovascular endurance better than it's ever been. The other version of you knows everything there is to know about Days of Our Lives, but she's out of shape, she's deconditioned, she's maybe even gained a little bit of weight, her core is not strong, etc. Then I'm going to reach into my pocket and pull out a Harry Potter magic wand and cast a spell of an attack of left leg weakness. She who had been exercising as part of her lifestyle is limping. She who is deconditioned is now in a wheelchair looking up. And I won't insult anyone by asking you who you'd rather be. But I'd rather make the point that the first version of you, we prehabilitated. We got you ready for what might come. The second version of you, we allowed to become deconditioned. And it can make a world of difference. And so it's terribly important. Now, mind you, it's not easy to exercise. And having MS makes it even harder. So we have to be creative about how we exercise.
Right. So speaking of being creative with exercising, with going to gyms or now physical therapy, I still go to my physical therapist, but my workouts have changed, and so I wanted to stay at home. I wanted to have a workout routine where I wasn't going to the gyms. So I started walking around my neighborhood for that cardiovascular, but then I also found this just on Amazon for like $25. It's called the Body Gym. And
how does it work?
Let me show you. So you just stand on it, and then so it's the stretch bands.
That's awesome.
But because it has this bar along with it, then now I have a lot more. I feel like I can utilize this, and I feel like I'm using gym equipment. So it's really helpful for me with that body training.
That's awesome.
So again, there's our water bottle. So again, it's not the same as before, but it's just a modification. So do you have any other ideas or suggestions on ways that we can get exercise from home?
Absolutely. I want to start by saying that's really freaking cool.
Yeah.
Good job. That's neat.
I love it.
We do have to be creative, and many of us have figured out the way we exercise is we go to a class, or we attend a gym, and right now in the COVID-19 era, that's arguably not the best option. And so I think that we have to be creative. If you have an internet connection, you have access to yoga, you have access to home workouts, you have access to a myriad of resources, including things curtailed for folks in a chair, things created for someone with motor fatigue, with MS, etc. And so there's a host of things that you can do. You can essentially jazzercise in your living room just by flipping on, YouTube. And so I think that's a really great resource, because most people have an internet connection on their phone or on their TV or what have you.
So creative and technology.
Yeah, that's exactly right. Definitely. I think we also have to sort of reinvent what we're trying to accomplish. I encourage people to try to go for a walk. It can be hot outside, so we want to do that in the morning before the sun's fully up so that we're not in the heat. It's also less foot pattern in traffic, and so that can be very nice. Alternatively, at night, as it starts to cool down before you go night-night, you can go out for a brisk walk.
And get that nice fresh air in too.
Yeah, and if you want to walk with your friend, you can walk with your friend. You can do it at this distance. We can talk to each other and walk next to each other. So the point here is you don't give up on the goals of exercise simply because you can't go to your gym. You do exactly what you just demonstrated. You come up with a creative way of making it work. I think that's really, really important.
Great, thank you. And so moving on, can you help us understand some of the physical and cognitive symptoms of multiple sclerosis? And if you don't mind, I'd like to really talk about the physical and then make sure that we also talk about the cognitive. And then, maybe a little bit, because I forget what we've talked about.
That sounds great.
Hey guys, before we move on, can we just back up to progression a minute? I have a couple questions.
Absolutely.
Okay, I have a question. What is the medical explanation for physical disability progression, in parens, clinical deterioration, but with stable MRIs? No new lesions, no new signs of active inflammation for the last 5 years.
So this is a very, very important question. Asking, how is it that I'm getting worse physically when my scans are stable and I haven't had an attack? And this speaks to that term I mentioned earlier, the so-called PIRA, progression independent from relapse activity. I'll explain it to you using an analogy. So full disclosure, I do not own a firearm, right? But just let's pretend that I owned a shotgun, right? So I'm going to take that shotgun and I'm going to blow a hole in that wall. All right, so now there's a giant shotgun hole in that wall. And they cart me off to prison, and all of you think that's weird, and they decide that they're never going to patch the wall. This is where that doctor lost it and blew a hole in the wall. So now this room happens to have a hole in the wall. Well, as this building ages, say 30 years from now, and as the material in the building starts to wear down, which wall falls first? The one with the structural damage. That is actually a rather accurate description of the brain damage caused by old attacks. So when you have an MS attack and it affects your spinal cord, and during your attack you can't move your legs, and then thank goodness after steroids and time and rehabilitation and hard work you regain your legs. 15 years later, as your spinal cord's aging, as your brain's aging, those areas wear out, and they are the underpinnings of where progression occurs. That's why it is so darn important to prevent attacks, to prevent new spots on the brain. And I don't like to use the word spot because I think it doesn't explain it. A spot is actually brain damage. So we want to prevent attacks and prevent new brain damage seen on the MRI in the now, because you pay twice. You pay at the time it happens, and then what I call the devil's price, you pay 15, 20 years later. And that's the underpinning of progression.
Thanks for that answer. I have one more question here, and then I think Stuart has a couple. If one experiences raw and pura, does that constitute your disease being secondary progressive?
In a word that rhymes with ho, no. And so the terms were coined in a very early MS clinical trial called the OPERA trials. These were patients that had had MS for less than 8 years. They all had relapsing MS, And when we studied them, a good portion progressed independent from attacks. And so that does not mean that you have secondary progressive MS. The reality, Jill, is that the old ancient 1990s concepts of relapsing, remitting, draw a line in the sand, secondary progressive are false. They're a oversimplification of reality. And every MS patient actually knows that. When you explain to them, they say, well, that's what I've been experiencing. My doc kept telling me it wasn't true. But you know your body, you're a you expert. And in reality, you can see both if you look carefully very early on.
Great. Now from the audience, we have a couple of questions. First one is, how common is dizziness with MS, and what are ways to combat and deal with dizziness?
Dizziness is a very frustrating thing to experience, and it's actually a very complex thing. So the first thing when someone says the word dizzy, I say there's 3 kinds of dizziness in MS. Let me describe them to you, and you tell me which one you're talking about. So the first kind of dizziness is I stood up too fast, and I feel like I'm going to pass out, and I have to wait a little bit. All right? That's actually called pre-syncope, and that's a form of dizziness. The second kind of dizziness is a term called vertigo, which is a hallucination of spinning in a circle. Either you feel like you're on a merry-go-round, or the world is whipping by you. All right? And the third kind of dizziness I describe as, if you've ever heard of the term drunk, or maybe you watched a television show and somebody on the show was drunk and they stumbled when they walked, or if you are on a boat and you don't have your sea legs yet, and that's called incoordination. And so the first thing I try to do when I hear dizzy is I try to put it into one of those categories, because there's a completely different treatment for each one. Now I'll teach you a secret. Right? So if you're in the room or if you're on the interwebs, don't tell anyone. There's a secret that physical therapists are amazing at rehabilitating all 3 of those kinds of dizziness. And there's actually very special physical therapists that had special training. They're called vestibular physical therapists. And they are remarkable at helping vertigo and helping ataxia and dealing with pre-syncope. So there are ways of addressing it. You know, dizziness sometimes can be treated with a pill, but more often than not, we have to do some hard work with physical therapy to overcome it.
That's great. And I truly understand what you're saying about vertigo, because I used to tell people that I feel like I'm a dot on a bowling ball heading down the alley. And there's no way to stop, and it doesn't seem to find an end point. It just keeps going and going and going. So,
it can be super, super frustrating, and you look so good. You don't look dizzy.
That's right. That's
you know?
right.
It's super frustrating because you're having this experience, but to the outside observer, they can't see anything.
Well, they could when I was on the floor trying to grab at tiles.
There you go.
Trying to grab at a tile floor and to stop the rolling. All right. So next question from the audience is, what is the key sign you have progressed to secondary progressive?
So I don't like the term secondary progressive MS because I think it doesn't teach us anything. So there is a very crass way of referring to a human as a buxom blonde, right? So if you say, hey, look at that buxom blonde, you're commenting on 2 very surface aspects of a human being. In reality, you don't know anything about that human being. You don't know the kind of music they like. You don't know their ethics or their politics or their religion or what they enjoy doing. You don't know anything. You're just commenting on the surface, which is not appropriate. And in my opinion, secondary progressive MS is equally inappropriate. It doesn't do the disease justice. In 2013, we redefined the terms that we use for MS. And if you've ever had a relapse, you have a relapsing form of MS. And someone with relapsing MS can have progression. And so a more accurate term is relapsing MS with or without progression. Words matter. Words matter a lot. And the other reason I don't like the term secondary progressive MS, many people in this room and online remember when there was no option for secondary progressive MS treatment. So if your doc labeled you as secondary progressive MS, suddenly you had no treatment options. We've become smarter, and one of the things we've learned is those medicines continue to help us, even when we don't have attacks. Those medicines slow brain volume loss, and they slow progression of disability, as we talked about earlier. They maintain the reserve, they preserve the reserve. And so I don't use the term secondary progressive MS in my clinic.
All right, now all the way out in right field, Dr. Boster, we have another question. Are there swallowing issues with multiple sclerosis?
So can people with MS have swallowing issues? Yes. And it's actually not very uncommon. And so if you gasp or sputter or cough when you're eating, I need you to take that very, very seriously. If I can be blunt for a second, there are 3 ways that people with MS die. The first way is a urinary tract infection that seeds the blood, urosepsis. The second way is a decubitus ulcer or a bed sore that seeds the bone. But a more common way is called aspiration pneumonia, where you put your meal in your lungs. And it can be silent. But if you're noticing that you're coughing or sputtering while eating, or if your spouse keeps like standing up and moving over to you in case you're choking, you need to alert your MS clinician, and you need to have a proper swallow evaluation because it's treatable. There are things that we can do to keep you safe while eating. It's very, very important. So don't ignore that if it happens, and it can happen pretty often.
So now it's back to the stage. It's up to you and Sarah again.
Sure. So we're going to switch over to physical, and we had talked a little bit about the spinning, vertigo. We've talked about the swallowing now. What are some other symptoms, physical and cognitive, that you think it's important for us to know about?
So I like your idea of dividing things by stuff you can see and stuff you can't. So if you think about stuff you can see, people with MS can have weakness, where a limb doesn't do what it's supposed to. So, you have trouble picking something up, or it drops out of your hand, or your leg is not strong. But it's more complicated than that, because people can have what's called motor fatigue, where they start off and they're fine. But after a bit of walking, or after a bit of exercise, as their core body temperature rises, they short circuit and they become weak. Then they have to sit and rest, and they can keep going. So you can have weakness and you can have motor fatigue, but it's more complicated than that. Because in addition to weakness, you can have what's called spasticity. Now, the people in the audience live in the great state of Ohio. And about 3 weeks ago, guess what happened here? It started to get cold in Columbus, Ohio. And I didn't need to know the weather, because in 1 week we had literally 30 phone calls from patients calling and saying, Lord God, man, I'm stiff as a board, I'm spasming, I'm having cramps in my leg, I can't bend my leg to get in the car.
I never thought that I wanted to live in Florida until about 3 weeks ago. And I said, I think that I want to move in Florida.
Yep. And so there's a tremendous amount of physical conditions that can impact MS. I could actually go on for hours talking about sort of the physical manifestations. But I would rather transition to the invisible, because the majority of MS symptomatology is invisible to the outside observer. Honey, you look so good. Oh, you don't look sick. So yeah, and you don't look ill-informed and stupid. But the reality is that people with MS don't leave the workforce because they can't walk. They leave the workforce because they can't think fast enough, or because they can't stay awake. And so when I think about invisible symptoms, I think about the up there's and the down there's. So the up there's is mentation, thinking and memory, energy, and mood. All 3 are very commonly affected in the setting of MS. And I'll tell you a secret. If one is impacted, it impacts the other 2. So if you have fatigue, it will impact your mood, and it will impact your cognition. But here's the good news. If you treat fatigue, it improves your mood, and it improves your cognition. That's the up there's. All too often, a doctor doesn't listen. How are you doing? Good? Oh, that's nice. Well, the person never got to share that they're having trouble continuing a conversation because you didn't engage them in one.
Right.
And I want to empower people. If you're having difficulty with mood, call it out. Say, no, we're not done, doc. I'm having trouble with my mood. I'm having trouble thinking. My kids are teasing me because I say I keep asking them to do the same thing, what have you.
So with something like the mood, would you call your neurologist? Would you call your psychiatrist or psychologist? Like, who do you start with?
So I want people impacted by MS under my care to call me when something's not going well. I'm board certified in neurology and psychiatry for a reason. And I think any MS neurologist must address depression. They must address anxiety. The reality is people impacted by MS are twice as likely to experience depression and anxiety compared to the general population. And this is completely treatable. We can treat anxiety, we can treat depression, and we can improve quality of life.
If we as patients are able to tell you and inform you.
Exactly. If you don't tell me, I can't see it. Now, I try, I ask, I give people questionnaires to monitor many of those invisible symptoms. I directly ask them, how's your mood? And then I'll say, well, what would your spouse say? Sometimes I get a different answer. And so we can work on that together. But it's all predicated on you being open and honest with me so that I can turn around and help you.
So I would say that it starts there on just being able to recognize that there's an issue from the beginning. Past that, other than our experiences, how is it tested and monitored? If it's something that we can't see, how is it monitored?
So there's a lot of different ways that we try to sort out how you're doing. And we'll stay on the topic of mood. We'll talk about depression. So sometimes, rarely, people get depressed like on TV, where they shell up in their bedroom and they listen to The Cure and they write sad letters and they wear all black. And that's actually a fallacy. That's not the way that most red-blooded Americans become depressed, particularly male red-blooded Americans. We just act shitty. We just act irritable, right? And all the wives in the audience are going, yep. And so we have to first identify that people manifest depression differently. We need to ask about, do you still enjoy doing stuff? You still enjoy reading? You still enjoy reading? No? We have to ask these difficult questions and try to get to the bottom of it. There's a tool that I like to use. It's called the PHQ-9. It's 9 questions. It very, very accurately identifies depression. And so every patient that comes to clinic, we give them the PHQ-9 so we can monitor and kind of watch that. Another way to do it is to ask their family, because I'll tell you a secret. The family knows, right? So oftentimes when I'm looking at the patient and I say, hey, how's your mood? I then make eye contact with the care partner, because the care partner will tell me the answer.
If they're rolling their
and
eyes
the patient
and going,
says,
oh.
I'm doing fine, doc, and the care partner's going back there like, and then they sit, quiet. And so the reason that's helpful isn't because the person with MS is not being honest. It's because they live inside themselves. The care partner sees them from the outside, and they can see aspects that the human being doesn't notice. And so I find both pieces of information very, very helpful.
Yeah, and we've talked about exercise and we've talked a little bit about diet, but that mental health, so meditating, I would say that that's been just as beneficial and just as necessary for me than exercise.
I 100% agree with you. I think that as we try to live our best lives despite having MS, we have to do a couple things as part of our lifestyle. We've touched on some of them. We touched on exercise. We touched on the importance of not smoking things. We touched on my opinions about exercise and diet, so on and so forth. But one that I didn't mention is a concept of mindfulness. Show of hands in the audience if you're familiar or heard of the term mindfulness. So some of us have heard of it and some of us are less familiar. Mindfulness is not some airy-fairy concept. It's the idea that you'll practice something that Americans almost never do. You'll be in the moment. You're not going to think back to bad things that have happened. You're not going to tell yourself movies in your mind about future scariness. You're going to really, really exist in the moment. One of the best ways to do that is to meditate. Mm-hmm. And a lot of times when people meditate, they're taught to focus on something in the now, like, for example, their breathing, right? There's other ways to practice mindfulness. Here's an idea. The next time you eat a meal, I want you to really, really think about what you're doing. I want you to pause and I want you to smell your food. I want you to pause and I want you to look at who you are honored to eat with. I want you to taste the food. Turn the TV off. Don't even talk for a little bit. Live in the moment and really enjoy that special moment of eating your dinner. I double dog dare you to do that for 5 minutes once a day. It is life-changing, MS or not. It's a really, really big deal.
I agree.
Too often, we don't do that. We go through our whole day and we never take a moment. You can find time. I'll tell you a secret. A great place to practice mindfulness is on the throne. No one's going to bother you, right? I mean, that's like culturally appropriate. I lock myself in the bathroom. So put your phone down for a couple different reasons. And take a moment and be by yourself and concentrate on your breathing.
Well, it just makes those moments enhanced, like driving here with the fall moving in and the seasons changing and the leaves changing. The drive here was absolutely gorgeous, and there was a time in my life before I started practicing mindfulness where I probably wouldn't even seen that. I wouldn't have recognized it. I was just so zoned in, and now I feel like I can appreciate those moments, and that just has made life so much better.
This has actually been studied, and people impacted by MS that practice mindfulness, they fare better. There's even a paper that suggests that patients that manage their stress have decreased accumulation of spots on their brain. That's a real scientific study. Very, very exciting, and something that we blow off all too often.
But it's actually really important.
Amen.
So we're going to kind of switch gears a little bit and talk about some MRIs, because we were talking about progression, and I'm interested in knowing
Jill is trying to stop us from transitioning.
Oh.
She's giving us quick hand signals.
I can't, maybe we should have swatched places, because I can't see Jill over here. Jill?
We have some questions.
So Sarah, I'm over here, and I can tell you when it's time for timeout.
Okay. I'll try to pay attention
We're going to
to
figure
you.
this out, guys.
Okay, I'm going to ask a couple questions that have come in online. One of them says, is biting my tongue something I should mention to my neurologist? Is that possibly MS related?
So this is an awesome question. The person asks, is biting my tongue related to MS? Should I mention it to my neurologist? So any thoughtful human with a chronic condition, any chronic condition, diabetes, cancer, MS, whatever it may be, who experiences something weird, their head itches, they bite their tongue, they're going to ask a rational question. Is it related to my condition? Remember, that's a rational, appropriate question to ask. And the answer is, it could be. So MS affects the supercomputer that runs the body, the holiest of holies. And it affects the superhighway that takes all the information from the brain down and back up. And so if you ask the question, could MS cause blank? The answer is yes, which makes it actually a bad question. And so my contention is, if something's bugging you, call us. Tell us about it. And if I don't think it's related to MS, I'll tell you, I don't think that's related to MS, but I think we need to have the conversation. So yes, you could have an MS problem in controlling your lower cranial nerves, making it hard to move your tongue. There's a bunch of different ways that can happen. And biting your tongue hurts. So yeah, you should tell your neurologist about it.
Great, thanks. Heather wants to know, can body temperature regulation be affected by MS brain damage?
In a word that rhymes with Hess, yes. So it's actually extremely common that people impacted by MS have trouble when it's too hot or too cold. When it gets too hot, you can have cog fog, fatigue, motor fatigue. Sometimes your numbness intensifies. It can be very, very difficult because of heat-related problems. And you can see that in Ohio during the summer months. When it gets cold, you get spastic and stiff, and it's hard to move. Or you could live in San Diego where it's perfect temperature all year round. But you know, many of us here in the Midwest experience 4 seasons, and that can be really challenging in the setting of MS. Very, very common.
Great, thank you for those answers. Now, I just want to remind the virtual audience that may not have heard my directions earlier, that you can type in questions online, and we will be, as you can hear, we'll be calling out those questions. And for those in the audience, I can't get around to everybody's table, so if you have a question that you want to give to me or call out, then just raise your hand and I'll get over to you. All right, so now though we do have a question. From a person in the way back of the room, says that she gets spasticity and wants to know if there's something she could do that does not require her to take a pill.
Absolutely. There's a lot of things you can do. So one of the most important things you can do with spasticity is to stretch. And so stretching is free. Stretching involves nothing but you, and stretching has a profound impact on spasticity in the now. Here's what I recommend. When you wake up in the morning, before you exit your bedroom, stretch. 5 minutes. Don't know how to stretch? YouTube will teach you. If you used to do track practice, do that. If you're into yoga, do that. Point is, I want you to stretch out, and I want you to stretch out your back, your butt, your hips, your quadriceps, your hamstrings, your calves, and that's going to get you started. Now, at night, when you go to bed and you enter into your bedroom in your night clothes, before you climb into bed, stretch. Same thing, 5 minutes. Then, I just need you to stretch once in the middle of the day. If you stretch in the morning before you start your day, and stretch before you get in bed, and stretch once in the middle of your day, that's 15 minutes of your life. I don't believe you that you don't have time to do that. It makes a profound difference in spasticity. Here's a second tip. Spasticity is always worse when you're still, like sleeping. That's why spasticity is worse when you wake up in the morning, because you've been still all night. Sarah drove 2 hours to come up here. And by the way, can we thank her for that? Some of my patients that come to visit me from Cincinnati area cannot make a 2-hour trip in one go of it, because they'll get out of the car and they'll be so stiff they can't bend their legs. And so thank goodness that halfway there's Washington Courthouse, and they've learned to stop at an hour, stretch, walk around for 2 minutes, jump back in their car. Then when they get to my clinic, they're good in the hood. And so I want each of you who has some spasticity to figure out, how long can I go before I get stiff? You can use this at work. So sometimes people figure out, I can last about an hour and a half. Set your phone to beep every hour and a half. Get up, do a lap in your office, sit back down. Very, very helpful and very, very free.
Thank you for that answer. What about marijuana?
Well, as long as it's not in a pill form, then it meets her criteria. Medical marijuana has been shown to help pain and spasticity in MS. And it's one of the options that are available in states that allow medical marijuana. Here in Ohio, MS is a qualifying diagnosis. And I have had several patients who have benefited from cannabinoids to help their spasticity. Is that the only option? No. Is it a viable option? For some people, absolutely.
Thank you. Next question. Before I get to that, I want to thank my video producer, Bill, for driving 18 hours to get here, okay? Because Bill would not get on a plane to fly up, and obviously there are many good reasons for that these days, so Bill wanted to make the drive, and he drove 18 straight hours to be here on time.
Thank you,
Let's
Bill.
thank Bill for doing that.
Thanks, Bill.
All right, next question. Can complex sleep apnea correlate with multiple sclerosis?
So sleep apnea is a phenomenon where when you fall asleep and you're laying down flat, all of the tissue in your neck relaxes and it can close your throat. Snoring is you trying to move air through a closed windpipe. Right? And if it's bad enough, you can't get oxygen and then you wake yourself up. That's an apneic episode. But you don't always wake yourself up all the way awake. You just go from restorative phase 3 and 4 sleep up to barely asleep phase 1. And when you explore this with people, sometimes what you learn is someone is in bed for 8 hours, they slept for 2. They actually got restorative sleep for 2. Obstructive sleep apnea, interestingly, is more common in MS than in the general population. Here's one way to sort it out. If you wake up in the morning and you're exhausted, that's not MS fatigue. If you wake up in the morning and you have a headache, that's not an MS headache. If your wife owns earplugs, that's not MS. If your kids can tell whether you're sleeping or not in the living room, that's not multiple sclerosis. There's a concern on the table that could be obstructive sleep apnea. Now, it's a wicked cycle because if you don't sleep, your MS symptoms get worse. And so we have to identify people that have sleep apnea, and then we have to treat it. The good news is you can treat sleep apnea, and it can be magical when suddenly you get a proper good night's sleep. I used to fly in and out of the Detroit airport a lot, And I was always struck by these businessmen. And you guys know, men don't carry stuff when we travel very well, right? And so they would have a briefcase in one hand and a little black box in the other hand. That was their CPAP machine, because they knew they couldn't go to a business meeting and not get restorative sleep. And so they bring their CPAP. And if a business guy travels with a CPAP, it must be really, really important, because he didn't bring underwear, he didn't bring a new tie, he just brought a briefcase and a CPAP. You can laugh at that if you like. Thank you for humoring me.
So sleep hygiene is extremely important as
my
well,
goodness.
right?
Yeah.
So how much sleep? So we've got the recommended 8 hours a night, but with the fatigue, is there anything that you can tell us about our sleep hygiene as MS patients?
Absolutely. Most people are not good sleepers, as my grandma used to say. Aaron, you're not a good sleeper. And so we need to budget time to sleep. Oftentimes, we cheat sleep. So I'll give you a great example. You have munchkins, all right? You get home from work, it's complete chaos at home, you're chasing after children, trying not to beat them and make them do their homework, and trying to get them ready for their project that you have to do for them, and it's extremely
You have
crazy.
dishes and laundry and getting dinner together and bath time and...
So finally, it gets quiet around 9-ish, right? And what do? It's adult time. So my wife and I do this all the time. It's adult time. What does that involve? Sitting on the couch, not talking, staring at the boob tube, right? And we want to have our adult time, and we sit there and stare at the boob tube for hours, and then we stumble up to bed around midnight, and then my alarm goes off at 5. Oops. So here's a pro tip. Take back an hour. Go to bed just 1 hour early and watch what happens. It's miraculous. You have to carve out time for sleep the same way you carve out time to poop, or the way you carve out time to call your mom. You need to dedicate enough time to sleep if you want to get good restorative sleep. And very often, people don't do that. We try to cheat sleep, and we really need to not do that.
So as far as napping goes, do you have any recommendations on how we should nap or how long we should nap?
I don't think you want to nap for more than an hour. If you nap for more than an hour, that's not a nap, that's sleeping. And so I know some patients that will nap for 3-4 hours in the middle of the day, and then they tell me they can't fall asleep at night. And you know what I see a lot is the person with MS is no longer a first shifter. Their sleep cycle shifts forward and shifts forward. I have some families where, and I'll use an example where the husband has MS and maybe he's not working, and the wife is working a 9 to 5. And the wife will go to work and come home when the husband wakes up. And then they may spend like a dinner together, and then she goes to bed, and then he's up all night. And he finally gets tired around 6 o'clock in the morning when she wakes up, and he goes to sleep. And they don't see each other ever because they've shifted, and so we have to shift it back. Very common, actually.
Right.
So if you're going to nap. I think naps are awesome. I'm a big fan. But you want to keep it short. Half an hour to an hour is what I would recommend.
Okay. Stuart?
I have one more question from Pamela. Pamela says, you keep saying care partner. What if you have no option and are fighting this alone?
So you don't get to have MS by yourself. You have MS with your village. Sometimes you have village members at home with you, right? I keep talking about a care partner. But if you aren't fortunate enough to have a care partner, you need to create a village around you. That could be your neighbor. That could be people at your church or synagogue or mosque. That could be a support group. That could be your book club. You don't want to have MS by yourself. I won't allow it. And it's very, very important to do this as a team sport. And so there's a million ways of meeting someone. The interwebs make that fantastic. And participating in a Facebook support group is a great way to meet people. And in the COVID-19 era, I oftentimes demand of my patients to video chat someone that they care about once a day. 5 minutes. Hey mom, Aaron said I'm supposed to call you, right? It can be magical. So I've yet to meet a human being who has zero contact with others. Even if it's your mailman, invite him in. Sit down, have a cup of coffee.
Connect. Yeah,
exactly.
Just connect with other people.
Yeah, exactly.
Yeah.
Thanks for that answer. I just want to mention, please, if we could move things a little bit faster. We have a lot of issues to cover. So, Dr. Boster, can you make your answers a little bit briefer? Thank you.
Nope.
And we're ready to move on to our next conversation.
All right, so MRIs and progression, what do they tell us?
So when you get an MRI, you learn a tremendous amount. First of all, MS doesn't just hang out in the brain, it hangs out in the spinal cord. So if you only image the brain, you're missing part of the disease process. And so I like to image the spinal cord every other year, every couple years. In the brain, there's a tremendous amount we can learn. And in the 1990s, we looked at the big glowing white spots. You don't need to go to doctor school to be like, wow, that does not look normal, right? The big glowing white spot. But there's a tremendous amount that we learn beyond that. For example, black holes. Show of hands if you're familiar with black holes. Yeah, good. A lot of people in the audience raised their hand. I'm curious if you raised your hand at home. I won't be able to check. And a black hole is an area where the inflammation was so intense it literally ate away at the tissue. Black holes are a better correlate to disability than bright spots. And so when you talk to your doctor and he shows you the scan or she shows you the scan and he says, oh, you have no new white spots, say, what about black spots? Because they're relevant. One of the biggest things we can learn from the MRI is brain volume. Size matters. And in MS, particularly untreated MS, there's an accelerated brain shrinkage. And so that's one of the biggest things I look at on the MRI is the brain volume. Very, very helpful as we're trying to understand progression. And that was my version of a short answer. You're welcome.
Is there a difference between white and gray matter lesions?
Yes. So the gray matter is the bark on the surface of the brain. That's what we do our thinking with. The white matter are literally the wires that connect the gray matter. When I was in medical school, I was taught that MS did not cause pain, MS only involved T cells, and MS only affected white matter. All three things are false. And the gray matter is actually very, very relevant in MS. The conventional MRI can't see it very well, but it's there. And you can use fancy pants MRIs to show it. But knowing it's there is adequate. It absolutely matters.
Okay. Do MRIs tell us anything about new or worsening symptoms?
This is a great question. So I learn about you three ways. The most important way I learn about you is stuff you tell me. Because you're a you expert. You're with you all the time. You know more about you than anybody else. And if I can shut up long enough to listen to what you have to say, I can learn most of what I need to know. The second way that we learn about you is what we see on the MRI. And those two things do not have to line up. The third way we learn about you is what we do when we do our exam or our neurological testing. And so those are three pieces of evidence. If you feel and look great, your testing's great, and there's new spots on your MRI, that's not okay. If your MRI is gorgeous and there's nothing new, and you're worse on exam, that's not okay. Most importantly, if your exam's the same and your scans are the same and you're doing worse, that's absolutely not okay. And any one of those things can be a problem, and they don't have to line up.
Okay. And so you talked about the fancy pants MRI machine versus a kind of a traditional.
Community, yeah.
Right, exactly. So is there anything that neurologists kind of request of patients when doing an MRI?
So the biggest thing is I ask you to do one every year until you're about 60. And that's not a small request. It's very expensive, and I have claustrophobia. So I take, when you tell me that it's hard to get inside of a small tube with a cage on your face, I take that very seriously. So I think just the fact that we're asking you to do an MRI is a really big deal. But I don't ask you to do things that aren't important. And I don't do things that don't change management. And so getting an MRI once a year and looking at your MRI is a really, really important thing. There are some doctors who, I can't believe this, they don't show the patient the scan. That's your brain. That's your body. And by the way, you paid for it. So I think you deserve to look at it.
Absolutely. All right. I always get in trouble because I fall asleep in the MRI machine, and the lady is like, psst, if you do not stay awake and you move your head again, I cannot get the pictures that I'm so please, for the love, stop moving. And I'm just like, I've been still.
Yeah, you can't win. You need to stay awake but not move. And then I love when they say, please stop breathing for the next 5 minutes. How am I supposed to do that?
All right, so what's going on in the MS world? I feel like my attention has been elsewhere, and even with the difference of progression that you had talked about, that was a term that I hadn't heard. So
Yes.
what are some new and upcoming things in the MS world?
There's a lot of exciting things happening in MS right now. The biggest one is we are literally on the fringe of having a blood biomarker for disease activity. Allow me to repeat. We are very close to having a blood test to tell us if you respond to your medicine and if you're at risk of an attack or getting worse.
Wow.
That's called neurofilament light chain. It's not a fantasy, it actually exists. It's not yet commercially available, but we're probably within a few years of doing that. And that will completely and utterly revolutionize how we manage multiple sclerosis. I'm super excited about that.
That's fantastic.
Yes.
That'll be a fun conversation to have.
Correct.
Whenever
Yeah.
it's time and ready and we get to learn more.
Yes, that's really, really cool. There's also a tremendous amount of new, exciting medicines that are being developed. I'll tell you about one really quick that I'm super excited about. At our center, we just launched a clinical trial studying a molecule called BTKI, butyrate tyrosine kinase inhibitor. Try to say that fast 3 times. And this pill that you take once a day does 2 things that we've never been able to do before. The first thing it does is it blocks B cell signals without killing B cells, which is kind of cool. The second thing it does, inside the brain, it works on a cell that we've never been able to modulate called microglia. And so we can slow down the nasty activity of naughty microglia. And I really think that this is going to be a very exciting new wave of research that will herald in a new way of thinking about treating MS. Very, very exciting.
That is really
Yeah,
exciting.
it's pretty neat stuff.
What about stem cell therapy?
Stem cell therapy is, at first blush, super sexy.
Right.
I'll go somewhere and they'll swap out my bone marrow and then I won't have MS. And let me start by saying that's not true, right? It's not a cure. Stem cell transplantation is not a medicine, it's a procedure. And if I describe it to you briefly, we take out your stem cells and then we murder you. We give you lethal doses of chemotherapy and radiation, and we remove your immune response permanently. We destroy your bone marrow. And then before you die, we give you back the stem cells and pray that they take. And you have a period where you're like John Travolta, boy in the bubble, because a cold would kill you. So it's not a mild process.
Okay.
It's very, very intense. And early on, when we started to do stem cell transplantation, unfortunately, people died. Now, we've gotten much better at doing it safely, but it's not prime time yet. So please listen to me. I'm so passionate about this that I'll show you my face. Do not have a tourist destination stem cell transplant. Right now, you can pay someone to go to an exotic location like India or Mexico or Chicago, and for a bunch of money, they'll swap out your bone marrow, right? But you need to be very, very cautious, and I don't want you to have a stem cell transplant outside of a proper clinical trial. It's not yet prime time, guys. It's exciting. It can help in some cases, but it should not be done outside of a research environment. I will now remask.
Thank you, sir. So there's many different options available to us now with the different therapies and some exciting ones coming up. But generally speaking, how will taking an MS therapy impact somebody's life?
So taking a disease-modifying therapy, to me, is one of the 4 most important things you do to control your disease. The natural history of MS is a doctor's way of saying, if I don't do anything, what do I expect to have happen? And I try really hard not to have to share that with people. I don't want to have that conversation. It's a very unpleasant conversation. I knew about the natural history of MS when I was 12 years old, as I watched my uncle deteriorate in an era before therapy. He went from being a brilliant musician and mathematician to not being able to read, to not being able to walk, to not being able to swallow, to dying at age 66. That was before therapies were available. I don't want that for you or your loved ones. We can change the natural history of the disease. We can left shift the curve. So you can live your life and not let MS make decisions for you. Not taking a disease-modifying therapy, in my biased opinion, is like a diabetic not taking insulin. It's really, really important to me.
Especially since we have the availability to do so now.
Yeah, there's 22 FDA-approved drugs. I have failed 0 times in my career getting someone on a drug. The only people in my practice that don't take a drug refuse to take a drug, because I can't make people do stuff. I can't make my kids do stuff. But I am allowed to tell you how important I think it is.
Yeah. Okay, thank you. Stuart?
Yeah, we have. Sorry about that.
Jesse is asking, are there studies on Hispanics with MS and progression?
So Jesse asks a very enlightened question about ethnic minorities in MS. Simply put, if you're not a pasty white kid and you have MS, typically you have a faster risk of progression of disease. That's true when you study African Americans with MS. That's true when you study Hispanic Americans with MS. That's true if you study folks that hail from Asia or East Africa with MS. That's true if you're of Middle Eastern descent and have MS. And it's been very well studied. It's been very well documented. And so that's an independent risk factor for more aggressive disease, is your ethnicity and background.
One more question here about MRIs. Does a vertical MRI scan warrant the same results as the tube MRI?
No. So the unfortunate reality is the open MRI is a really crappy image. That stinks because an open MRI is less, claustrophobia inducing than that tube. But you need that tube oftentimes to have proper images. You're going to spend upwards of $3,000 just to have an MRI of your brain. That's a lot of money. That's a tremendous amount of money. And I want that picture to be pristine because I'm trying to look at the holiest of holies, the supercomputer. And so I want really good pictures. There are times when I would rather someone not get an MRI than have a poor quality MRI because they'll be out the money and I can't tell anything. Now, technology is always advancing, but typically speaking, those easy breezy MRIs are unfortunately not of very high quality.
Great, thank you. Next couple, as long as they don't fall asleep, it's a high quality image, right?
Apparently, yeah.
Right, apparently. All right, so going backwards a step, a person who's asking from the audience, what do you do if you can't fall asleep until 2 or 3 a.m.?
So we have to attend to sleep hygiene. What time are you waking up? So what you need to do, first thing, is you need to time lock the time you wake. Make the time you wake 8 a.m. So you can fall asleep at 2 in the morning, but you have to get up at 8 a.m. And at 8 a.m., the bed is not available to you. If you force yourself to wake up at 8 a.m. and you don't go to take a nap, guess what happens? You get really, really tired. Do that for a week, and you won't go to bed at 2 o'clock in the morning. You go to bed at 10 p.m. Now, it's easy to say. It's actually very, very hard to do. And during it, you're going to cuss and swear at Aaron. But if you time lock when you wake up and adhere to it, you will reset your clock, so to speak.
Because at the end of the day, we're all habitual. It's just changing our habits.
Yep, that's exactly right.
Awesome. Another question. Can you have MS damage in the lower spine area, the lumbar area, and would you need an MRI of lower spine to determine this?
So, multiple sclerosis affects the central nervous system, brain, optic nerves, and spinal cord. But statistically, you're way less likely to have lumbar lesions because the lumbar spine is really, really thin and there's not very much myelin. So you're way more likely to have lesions in the C and the T spine. I do not image the L spine. I don't find it useful. Now, there are other weird things that can happen in the lumbar spine, but it's not a very, very common area. I have seen it. It's super uncommon. Typically, I can figure it out based on my neuro exam. Then I know what to look for. But as a routine, I do not recommend an L spine, and the consortium of MS centers, of which we're a member, agrees.
Okay, another question from center field now. Are they doing studies on arthritis and MS yet?
So if you have one autoimmune disease, you're at higher risk of having a second autoimmune disease. Now, there's different kinds of arthritis. There's osteoarthritis that all of us that live long enough get because we keep using our joints and they start to wear out and hurt. And then there's rheumatoid arthritis. Rheumatoid arthritis is an autoimmune condition. And if you have MS, you're more likely to have an autoimmune condition. You can have rheumatoid arthritis. There's other kinds of autoimmune arthritis like psoriatic arthritis. And sometimes, as my late mentor used to say, nature can be a little too generous. And you can have MS and RA. And I have several patients like that.
Up to you guys.
Back to me, huh?
Back to you.
All right. So, Dr. Boster, what are some of the benefits of seeing a neurologist who's part of a comprehensive medical center, and what is a comprehensive medical center?
So it's really about one-stop shopping. So the most important thing in my mind is not the whistles and bells, but the relationship. So I've talked to many patients who don't have a fellowship-trained neuroimmunologist at a comprehensive center. They have a very, very compassionate general neurologist that's a good listener, and that's better. So the most important thing is the relationship. But there's a lot of things sometimes that people with MS need in addition to just seeing their doctor. You mentioned earlier physical therapy. People with MS might benefit from having a trained listener, talk therapy. People with MS might benefit from having a speech pathologist. And so at MS centers, we tend to bring all those tools together so that we can offer the breadth and depth of what's available. And so that's not a requirement, but it's really nice.
Yeah.
And it saves an extra trip sometimes. So for example, if you see your neurologist and you receive an infusion and they're in different locations, that's not bad, it's just a little more difficult. If they happen to be in the same location, then you can kind of do what we call a twofer, where you get two things done at once.
I like that. I like getting two things done at once.
Yeah, it's just convenient, it's easier.
Well, and whenever you're dealing with cognitive issues, when you're dealing with fatigue issues, to have something all right there under one roof and one location, so you also don't have to worry about getting lost going to the next location, it's really nice.
Or just like the realistic reality of having to get off work. You know, so if your neurologist says, I'm going to send you to a therapist, you got to have an infusion, you need an MRI, you got to see a speech pathologist, you can't take 4 days. You're going to use all your vacation time just to do one visit. And so anything you can bundle can be very helpful.
So with all of those different categories under one roof, who's the team lead? The neurologist?
No, the patient.
The patient.
So the patient and the family is at the center of everything. And we are all team members. And so we want to be good team members, but it's all about you. And it's all about trying to make you the most awesome version of you possible, despite having MS.
So does that ultimately make us responsible for the information that gets shared between the patients and the doctor?
No, it's not your responsibility to tell one subspecialist the other subspecialist information. That's not fair. My point is, it's your body and it's your brain, it's your life. You only get to do it once. You're at the center, and then we need to move around you to help you. A long time ago, I went with a family member to a urologist, and we sat in this office for a long time, and on the wall, there was a picture of the urologist, his face, and then there was all of his staff around him, and under it, it said, Dr. So-and-so's team. He completely missed the point. We have at our center the same thing. There's all the team members around, including me, and in the center is a mirror. And that's your team. And I think that's a better way to think about it.
That is really great. Thank you. Stuart, Jill, any questions? Okay. So something that's been on everyone's mind, COVID-19. How does COVID affect somebody with multiple sclerosis?
What a question.
Right? Let me give you something easy.
Who thought that we would be living in a global viral pandemic? I mean, quite literally, it's insane. I think that we actually lack language to describe what we're all going through. There is a global mental health crisis right now because of this. And I spend my life caring for people impacted by MS. I can tell you with authority from experience, I've treated more MS attacks since March than I ever have in my life. I can tell you that people are suffering from depression and anxiety at way higher rates than I've ever seen in my entire career. To think this doesn't have an impact, or to think that stress doesn't have an impact, is to not understand this disease. And guys, this is stressful. It is a tough time. You gave an example. You're committed to exercising as part of your lifestyle. You did that by attending a gym. You can't do that right now. That stinks. It's a tough, tough time. We can't do the things that we figured out that worked for us. And we are obligated to find different ways of achieving the same thing. And that's not easy to do at all. This is very, very challenging. Very challenging.
Going forward with what you were saying about the depression and the mental health and whatnot, MS Views and News and the other MS organizations are doing more and more to provide for different types of programs for the MS patients to learn about this and how they can combat it and how they need to get treated. So you'll be seeing a lot more of that coming out in the months to come. And I just wanted everybody to know about that as well.
Thank you.
Okay.
Yeah, we'll look forward to it, Stuart. Thank you.
Great. And Sarah, you're doing a great job up there. I want to let you know that in front of everybody. Everybody say, "Yay, Sarah!"
So, thank you.
I have another question to ask first before you get into your so.
Go ahead.
Okay. Is there anything available to take besides steroids to treat a relapse if you have bad side effects from the steroids?
Yes. So show of hands, people in this room who are familiar with the drug Acthar. 4 of you. So Acthar, ACTH, was FDA approved in 1952, before we invented steroids. It's the oldest FDA-approved drug to treat MS that exists. Acthar, ACTH, is not a drug. It's a hormone harvested from pigs' brains. It's extremely challenging and expensive to get a vial of it because you have to harvest it. And when you take ACTH or Acthar, it makes your body make its own steroids. I'll give you a quick example. I have an absolutely wonderful patient from a wonderful family. I love them very much. And she had an attack. And she has type 1 diabetes. And if we give her steroids, we have to admit her in the hospital to give her IV insulin drip. And there's no way she's going to go to the hospital because of the risks of COVID. And so we instead used Acthar, ACTH. And she injected Acthar herself for 5 days in a row, and her sugars barely went up. And so, yeah, there are ways. There's IVIG, there's plasmapheresis. There's multiple different ways of treating an attack. Now, the mainstay that we start with is typically steroids, but sometimes we simply can't do that. And so we have to be creative, and those other options are very viable.
You have your plan Bs.
Plan B, Plan C, Plan D.
Exactly.
So next, and it's not from the audience, but something that I believe that everybody should know about, can you please tell everybody about the CoV-MS registry?
I can, but I want you to tell them.
I don't want to tell them. I want you to tell them.
So right now,
it's not my place to tell them.
Right now, there's a very exciting opportunity, I think, for people impacted by MS to change the world by sharing their experiences with exposure to COVID-19. And this is a grassroots effort by MS organizations around the world to collect this information. It's very, very important because this is a frontier that we've never been on before. And so the only way that we can learn is by learning from each other and collecting information. And just like with a clinical trial, if nobody participates, we can't learn anything. And if people participate, it can be life-changing.
Okay, and another question along those lines is people are always asking about what medications are safe for them to take during this time.
How much time do we have?
3 minutes.
All right, I can answer this question in about 4 hours. So the first thing that I want you to know is that having multiple sclerosis in and of itself does not increase your risk of contracting COVID-19, and it does not increase your risk of a more severe disease process unless you're motorically disabled and can't move your arms and legs very well. Having multiple sclerosis by itself is not an immunosuppressed state. On the contrary, your immune system's heightened. And so having MS in and of itself does not increase the risk of a more severe disease. The MS medicines that we give you, some of them have no impact on suppressing the immune response. Some of them suppress your immune response very significantly. And so the drugs that we give you can have an impact, not on catching the disease, COVID-19, but on the severity if you were to get it. And there's a lot of other factors that we have to consider. Morbid obesity, Age over 50, 60, 70 is an increased risk. Comorbid heart disease, comorbid lung disease. I'll tell you a horrible statistic. People who smoke cigarettes and get COVID are 14 times more likely to die. Not twice as likely, but 14 times more likely. That's an independent risk factor for a very severe outcome. And so my point here is, it's not one size fits all. And you're not MS, and you're not Avanex. You're a human being trying to live your best life during a global viral pandemic. And we have to sit down and game out what are the risk factors and what can we do to strategize to limit that. I'll give you an example of a young lady who has god-awful MS, and we had to use a very, very potent immunosuppressant to control her disease. Right now, she barely has an immune system. That's scary, unless you realize that she is an expert at quarantine. She works from home. They have an entire system in their house for her daughter and her husband. They don't interact. They literally have things brought to the house. They have a cleaning process. It's really, really impressive. And she has kept herself very safe, and she's doing awesome. And that's a lot of hard work.
So again, resourcefulness, creativity, and hard work.
Exactly right.
You know what you want, and you make the changes in your life to make that happen.
That's exactly right. You know, there's a lot of doctors right now that mistakenly are being paternal, and they're denying patients their drugs in an attempt at protecting them. Now, when I was in med school, I never took a course on being paternal, where I got to tell you your risk aversion. I got to tell you, honey, that's not okay for you, or you have to do this. That's not our role. And I think that we have to think about the risk-benefit of not treating your MS. This global viral pandemic will end. Your MS will not. And so it's my strong opinion that we have to treat the disease and prepare and protect ourselves so that if we do contract COVID-19, we can fare as good as possible.
So when this first came out, and then I had heard that MS patients were not more at risk, I thought, okay, I feel comfortable with that. And then they started talking about the cytokine storm. And then I thought, well, surely that has to affect us though, right? And I did kind of worry about that. So can you talk a little bit about that?
I think the reality is that there's a lot we just don't know. And I think neurologists are humans, and when we don't know stuff, we sometimes make it up because we try to connect the dots the best we can, and we try to make logical decisions. Mm-hmm. The bottom line is that I think we have to look at the individual human. We have to look at the risk of treating their disease, the good, the bad, and the ugly, the risk of what their exposure might be, and then we have to game out a plan. And all of these factors, it's a moving target. I mean, if you look at so the two places that I learn about COVID are the CDC website and the WHO website, the World Health Organization. And those are supposed to be relatively reputable, and they have vacillated back and forth. Don't wear a mask, wear a mask. Don't wear a mask, wear a mask. We don't know, we're learning. And so it makes a lot of sense to be separated from someone else so they can't spit on you. It makes a lot of sense to sanitize your hands. It makes a lot of sense to not party at Put-in-Bay with a bunch of people in really close proximity. Those aren't good decisions right now. And we are learning.
What about the decision to keep your doctor's appointments?
So I opened a brand new MS center on March 19th, 2020. The governor of the great state of Ohio closed the state on March 21st, 2020. I did clinic for 2 days, and then the state closed. Whew! So we looked at each other and said, shit! And then we had to figure out what to do. And we decided we would do telemedicine. How much telemedicine had I done in my 14 years of work? None. We had to figure it out, and we did. And right now, 70% of our visits are done via telemedicine. So that if you come in the clinic, we're only bringing people in that really need to come in because they are getting an infusion or something. And so we try to keep people at a distance when we can. Stuart, you have a comment or a question?
Yeah, so at the beginning of this whole nightmare, Dr. Boster and I were talking about the need for people to know about telemedicine. And so we put together an actual call. Now imagine that. He played MS Neurologist, and I played the MS patient. And we did a real call online. We had a lot of people, we had hundreds of people watching this program where he played doctor. Imagine that. Is he a doctor? We had him play doctor, all right? And anyway, it was a very good call, and people are still watching this. And we have it listed on both his YouTube channel and the MS Views and News YouTube channel, and people are still learning how to do telemed calls. I'm sure that many of you in this room have done this already. If you haven't, and instead you're concerned about getting out of your home to get to the doctor, whichever doctor it might be that you need to see, consider a telemed call. You will get most of your answers resolved right there and then, especially the most important ones that need to be resolved. And you'll feel better about what you did, and you know that your doctor is in control of what's going on with you.
One of my favorite new things to do is to review an MRI on Zoom. I pull up your MRI on this big Thunderbolt screen that I stole from my wife, and I swivel my iPad around so you're seeing what I see. And I can show you your scan in your living room. It actually works amazingly well. I really enjoy doing it, and I think it's pretty high quality. Let me share with you the future. By the way, people with MS and chronic conditions have been demanding telemedicine for decades. And it took a global viral pandemic when a bunch of otherwise healthy people suddenly needed to have access before we started it. And I hope to goodness gracious that it remains this way, even after the global pandemic. But let me share with you a project that we're working on. We're building 9-hole peg tests. And it's our plan to mail them to some of our patients with a ribbon that's 25 feet long. Because I can watch you on camera while your spouse times you as you do the 9-hole peg test. I can time you as you do 25 feet down your hallway. In other words, it's not just about asking you how you're doing. It's not just about having you fill out surveys that I read. It's not just about going finger, camera. But there are actual validated tests that I think that we can do remotely. And we can really make sure that we're winning and we're watching what's going on.
That'd be great. Thank you. Well, I think that might actually wrap it up. Stuart, do you have any other questions?
Yeah, did everybody enjoy this tonight? That's great. That is great. You know, some people have asked me before I say thanks again to the two of you. Oh, thanks again to the two of you. All right. But they were asking me, why did I change my mask? I mean, certain people. It's refreshing to put something different on, all right? Sometimes you feel like, wow, what's growing inside this mask that I have to wear all day long, all right? Well, change it out. I walk around with 3 different masks in my pockets. It feels good to change it out. I also feel like it might have been worn this morning, but it feels like it's brand new going on my face again, all right? So, we can make do with what we have. We're living in a very uncertain time. We want this uncertain time to end soon, but let's try to do it as best as we can all do it, all right? And telehealth, visiting your doctors, changing your mask, doing what needs to be done, staying away from people, all right, is a great thing. So now, and don't forget to wash your hands. I was just told that too, right? So I do want to thank Sarah. You did an excellent job.
Thank you.
Excellent job.
This is my first time doing this.
That's
so
right.
That's why he keeps thanking me.
Put her on the hot spot tonight, right? And Dr. Boster, well, I can't say enough about Dr. Boster. So he has been doing programs now with us. I remember our first program we did together in Cincinnati, okay, many years ago already. I mean, he's now spoken for us like maybe 16, 17 times over the years. But our first program in Cincinnati, I'm meeting him for the first time. He's got to be a showboat, comes running from the back of the room to the front of the room, jumps up on this 3-foot stage. This is short for him. He's got to yell out his howdy. Didn't like the answer. Went back, running back to the back of the room, came charging up again, and yelled out howdy so loud it was demanding for you to do the same thing in return. Then, though, we're doing our program, and he's running around the room to make his point heard, and he doesn't realize the cameras can't follow him because of the patients. We can't put the cameras on the patients. So I'm screaming out, no, you can't do that.
So I respond very well when I'm told I can't do things. And when we started, Stuart, who I never met, said, hey, you can't leave the stage. And I thought, watch. And I didn't understand that we couldn't leave the stage because then nobody could see. So that was a fun lesson.
Yes. But we're together. We do these things as best we can. That's the new handshake. But I don't understand that handshake either, because now you got to get within 6 feet, right, to do that. So, okay, we do whatever we can, all right? But we don't have to wash our hands after doing that kind of handshake.
We just have to wash our elbows.
That's right. All right, so firstly, I want to thank everybody for being here tonight. I do appreciate that you did come out of your homes, that you did do this event. Of course, I already said thanks to our 2 guests here on the stage. My staff, can't do these programs without them. Everybody that's watching from home, thank you, all right? We're doing this to make it doable and for everybody to learn from whatever's going on with multiple sclerosis. We try to cover as many topics as we can, and we're going to keep on doing this. Again, we have programs coming up. Well, next weekend. Let's talk about next weekend. You all need to hear about this too. We have our annual MS Symposium. Normally, it's just a South Florida event that we do as well. We put it online. This year, it's all virtual. So we've got 5 different speakers, and Dr. Boster will be speaking. He's our anchor person. We have Dr. Ben Thrower from Atlanta, Georgia. He's our first speaker of the day. Following Dr. Thrower is Dr. Mitzi Williams. Following Mitzi Williams, we have a patient advocate named Paul Pelland, who's also known as Long Haul Paul, for trying to drive his motorcycle 1 million miles for a cure. All right, and by the way, he's up to about 600 and something thousand miles doing this while having MS. All right, we then have Rick Harris, who's a psychologist, and what is he going to be speaking about? Mental health. All right, very hot topic. All right, and after that, again, we have Dr. Boster. How are we doing this all, though? Well, I'll be at Bill's studio just north of Orlando, and everybody else will be virtual. And we have to tie all this in to make it like seamless, that we're going from a person speaking to their Q&A, to the next person speaking, to their Q&A, and the next and the next and the next. And it's going to be a phenomenal event. So phenomenal that as of a few hours ago, 315 are registered online for this. All right? And we're hoping for a number closer to 500 by the time this event happens. Again, this is happening next Saturday. You have gotten emails about it. You will be getting more this weekend. Everybody, virtual, in person, whatever, you will be knowing about this event, and we do want you to be on there. So we do hope you do. And again, thank you again for being here tonight. We do hope to be back here, I don't know, but soon, okay? That's all I can say. I said earlier that our last event in person prior to the pandemic was right here, and we hope to be back here again, hopefully before too long, all right? Let's make the gap shorter between March and now than it was between now and our next one, okay? And again, thank you for coming. Have a great night, everybody. We're done.